Next, I would like to welcome Gargi. Gargi is known to most of the people here, but to start with, she's a colleague, very dear colleague of mine in pediatric clinic, and she's passionately involved with her little kids, and I welcome her for the talk with child with diplopia.
Okay, good morning, one and all, and thanking Nana Madam KSOS for this opportunity. So, a child with diplopia, how can we tackle the situation? So, basically, how is diplopia different in a child? So, let me go through that. For one, is this the symptom may be difficult to recognize in children. It is sometimes difficult even in adults. They may not complain of double vision. So if you see frequent squinting or eye covering, eye strain, headaches, difficulty with coordination, frequent falls, definitely unusual head positions, avoidance of certain favorite activities, like sudden avoidance of his favorite video game or television, nausea, dizziness, this may all make us aware of this unpleasant symptom. Now, for us to tackle, we should know the usual causes in children. So, children can also have monocular diplopia. It's not exactly diplopia. Usually, these conditions cause more than one image: polyopia, halos, ghost images. But definitely, you have to be aware of uncorrected astigmatism, anisometropia, poorly corrected, the spectacles may not be good, keratoconus, etc. But we are more worried about binocular diplopia. And binocular diplopia occurs whenever there is disruption of binocular single vision. So this is where again it differs from an adult. Because in children in less than 7 to 8 years, when the visual system is immature, it immediately, whenever diplopia sets in, it immediately within days to weeks, it goes in for cortical suppression and amblyopia. And so it's just a small window period when the child has some unpleasantness and where we can intervene maybe. And after 8 years, it's almost like adults where they will have diplopia. Now, what are the causes of binocular diplopia? The first cause everybody will think of is definitely the most important: paralytic, trauma, tumor, raised ICT, and even a decompensated congenital palsy. Thankfully, a variety of non-paralytic conditions can also cause diplopia on and off. A decompensation of any four areas, the increasing acute comitant ESO, intermittent EXO, the vertical deviations, Duane's, decompensated Browns. These are all patients with binocular single vision, so they may have diplopia on and off. And consecutive strabismus, and of course convergence insufficiency, where they complain of diplopia for near. Then all the varieties, the trauma, tumors in children, even vascular lesions in certain predisposed children, neurological conditions of raised intracranial tension, demyelinating diseases, and of course of ocular myasthenia should pass through our mind whenever we get something which is not conforming to any particular nerve palsy. Inflammatory conditions can occur like myositis, and very, very rarely we may even think of malingering, though it is very, very rare. Now, Falcon et al. Has done a very good study in 244 pediatric patients, and they found that thankfully 50% were non-paralytic strabismus, causes of diplopia in children. Only 9% were cranial nerve palsies and 9% trauma. And the same study has also found out that an acute onset of diplopia and associated neurological symptoms pointed towards a vision or life-threatening condition. And we can add on to this list papilledema, disc pallor, a front pupillary defect or other pupillary abnormalities, headache. They are all red flag signs. I mean, diplopia itself is a red flag. These make it more bright. With regards to asking the history, we are asking the parents, and they may sometimes not think some history is relevant. So you can ask leading questions with regard to these symptoms: fever, seizures, weakness of limbs, diurnal varia, especially trauma. They may not think the trauma is important enough to report. So only if you ask a pointed question, they may come out with that. Family history of diseases like senile or fibromatosis, vaccination history, pre-existing strabismus, and a family album is definitely worthwhile looking into. It's even called a family album tomogram to look at head tilt and all which was present from early childhood. Now, in evaluation, everything for squint has to be evaluated. The important points could be abnormal head posture, facial asymmetry, all pointing towards an earlier onset. Extraocular movements, ductions, versions, definitely because the movement defect can be very, very subtle. Again, an uncovered test will bring out phorias because the palsy can be very subtle. It is mainly diplopia which comes first, and later we may see the defect. So don't forget the secondary deviation. Now, children may actually cooperate better than adults, and they are more sharp and intelligent, and we may get a very decent diplopia charting if you spend some time, especially with the older child. Then in vertical deviations, the Park-Bielchowski and the vertical fusional amplitudes, if you suspect it is a congenital fourth nerve. Now, visual acuity, if amblyopia is present, again it points towards a slightly chronic etiology. Fundus for papilledema, disc pallor, torsion of the fovea, pupil definitely, and ptosis. Don't ever forget ptosis, which is a very important finding, and proptosis. Now, coming to investigations, they go usually under the purview of the neurologist or neurosurgeon, to whom we always refer these children. But we should know that the imaging of the brain and the investigations for myasthenia may form the major aspects. Now, as ophthalmologists, how can we manage? So, first is the management of all our refractive conditions, the astigmatism and isometropia. Look at the spectacles, any misaligned optical centers. If it's convergence insufficiency, give a start on active orthoptic treatment. And of course, it is a very unpleasant symptom. So, patching or the opaque tape on spectacles still is the most important management. But we are dealing with a child, so always remember to patch both eyes alternatively. Now, prisms will help us definitely in the interim period when we are waiting for it to subside or to act or to do a definitive procedure. We can divide in between the two eyes. So a ground-in prism is more expensive but with good optical quality. Very small powers, just around 10 prism diopters can be given, and we recommend it only for very stable prescriptions. So Fresnel prisms are more ideal, lightweight, cost-effective, and thin, and we can have in a more wider range of powers. Botulinum toxin definitely again in the acute comitant, acute paralytic, postoperative it is given. Different formulations are there. Botox is the usual favorite. So many formulations. The dose depends on the formulation used. 2.5 to 5 units usually. GA, general anesthesia, is required, and it doesn't even require an EMG in the expert hands. Can directly inject into the muscle. Surgical management, ideally, not ideally, you have to wait till the deviation is stable for more than 6 months at least. And the aim is to give binocular vision in primary gaze or to extend it to the reading position also, and correct abnormal head posture. So, multiple stage procedures may be required. It depends on whether it is a complete palsy or whether there is some residual action of the muscle, amount of deviation, whether there is contracture of the antagonist, etc. And a variety of surgical procedures are available according to the condition. So that is all. So we have to make it clear for them, because the window period available in children is very less. Otherwise, it will go in for a permanent suppression and amblyopia. Thank you.